Thank you, Jamie. All right, today's didactic is a continuation of our ADHD theme. So for today, we're going to focus on Qelbree. So this is one of the new treatment options for ADHD. Last week, we spent some time looking at the stimulants and all of the different products that we had there. Today, we're going to spend a little bit of time focusing on a new medication for the treatment of ADHD. So since this was newly approved, we're going to do just a general overview, talking about the pharmacology. So how does this work? Looking at some of the pharmacokinetic considerations, as there are some drug interactions that we do need to worry about. And then we'll look at some of the clinical trial data. Most of the clinical trial data for today that I'm going to focus on are just for the pediatric and adolescent indications. All right, so let's get started. So Viloxazine is our newly approved medication for ADHD. Officially, it was approved by the FDA with the indication of treatment of ADHD for children and adolescents ages 6 to 17 years. When they did their clinical trials, we're going to look at 6 to 11 and then 12 to 17 because they did split them out separately. This is an extended release capsule. We'll look at some of the release characteristics here shortly. It can be administered just once a day. The capsule can be taken on its own, or you can actually open it up and dump the beads into applesauce. They shouldn't be chewed or crushed because it is extended release and that would release it all at once. So that should be swallowed whole, either the label says applesauce, but it looks like you could also put it in pudding as well, if that's easier for the individual to swallow. Once you put it in the applesauce or the pudding, though, it really has to be used within a couple hours, otherwise it starts to degrade. Our dosing. So with this Viloxazine, they did split the dosing slightly. Likely this is due to some of the tolerability considerations. For children who are 6 to 11 years, they recommend it starting at the 100 milligram capsule and then titrating by 100 milligrams up to a maximum of 400 milligrams daily. For the 12 to 17-year-olds, you could start at the 200 milligram and then increase up to the 400 milligram afterward. They only currently make 3 different strengths of capsules, the 100 milligram, the 150, as well as the 200. So that does restrict your ability to do some individualized titrations. So I would say just kind of keep that in mind. It really looks to be locked in at intervals of 100. How does this one work? So we talked about the stimulants last time, being that they're targeting our norepinephrine and our dopaminergic neurons. For this particular product, it's a norepinephrine reuptake inhibitor. So it would be something similar to an atomoxetine. So just blocking the reuptake of norepinephrine and allowing more of that to be present to help with the symptoms of ADHD. So a little bit different. It is not a controlled substance. So it can be written on a traditional prescription with refills. So it doesn't have some of those logistical complications. And I apologize. I bit my lip yesterday and now it's all swollen and I keep biting it now as I'm presenting. So if I fumble over my words, I apologize. So norepinephrine reuptake inhibitor, that's the pharmacodynamics. That's what the drug does to the patient. Let's also take a peek at the pharmacokinetics. So what does the patient's body do to the medication itself? It is an extended release product. In the capsule, it contains a number of extended release beads. They are relatively bioavailable, more than 80%, almost 90% for the immediate release component, slightly lower with the extended release, but it depends on if the patient's eaten. So if the patient has a high-fat meal, then it actually will lower the absorption and it can delay the time for the medication to get on board. So not that they can't take it with food, but it would impact the absorption just a little bit. They see effects of this within the first 30 to 60 minutes, so they can detect serum concentrations. It reaches its peak at 5 hours. So we'll talk about some of the side effects. This would be something to keep in mind. If a patient is experiencing some adverse effects from the medication, then we may want to play with the timing of when we're administering this, to try to get away from that peak concentration being really problematic for them. So if you think about a child that's in elementary school, we don't want peak concentrations and the worst of the side effects to hit when they're in school. From a distribution standpoint, so how does it get to everywhere it's supposed to go throughout the body? It is there's a good amount of it, more than 2/3 is bound to proteins in the body. And they did provide some serum concentrations, which I think is interesting. It was in the prescribing information. They're not linked with therapeutic effect at this time. So it's not necessarily that you get this serum concentration and we would expect an effect, but just within the dosage range of 100 to 400 milligrams, these are the ranges of serum concentrations that they've seen. So in the event that you are drawing it, it is kind of nice to have. Usually we have to search for that a little bit more. Next step in the pharmacokinetics is how do we break it down and get rid of it? So we absorb it, we get it into the body. How does it get to everywhere it's supposed to be? Now, how do we start to break it down and get rid of it? It is relatively highly metabolized. So it uses a number of different enzymes in the body. So it did not have pharmacogenetic labeling information. Cytochrome P450-2D6 is prone to different polymorphisms with more rapid metabolizers. At this time, they don't have information for what else would need to be done. So it looks like it's kind of a combination of all of the enzymes and not only reliant on the 2D6 enzyme. Half-life is 7 hours. So that means steady state would be reached at about 35 hours, so about 2 days or so to get to new steady state concentrations. So checking in within a few days to see from a tolerability standpoint would be okay at this point. From an efficacy standpoint, we probably wouldn't see it that quickly, but at least from tolerability, if they're having trouble with side effects, we could see an improvement pretty quickly, which is nice. And then the body gets rid of it renally. So there are some suggestions for reducing the dose with a maximum of 200 milligrams for those with severe renal impairment. As promised, so this actually came from the main webpage for this product. It is extended release. These are just artist rendition of the beads that are within the capsules themselves. So they do have layers that are both immediate and extended release to try to provide some medication throughout the day. They did some of their pharmacokinetic modeling studies, which don't appear to be fully published at this time. It's all just released through the manufacturer. So I couldn't get all of the information that I was looking for. So they didn't release a whole lot on the characteristics of the beads, but just that they do see pretty significant release right away. So as I said, that absorption happens quickly. We can see serum concentrations within the 30 to 60 minutes, peaks right around 5 hours. And then we see kind of a slow decline of those concentrations over the remainder of the 24 hours. So if we do need to make modifications to some of the dosing, it would be possible to give a dose in the evening, although most of the recommendations are for the morning, or in the later part of the day to get some coverage throughout the day, so that maybe the patient can sleep through some of these adverse effects. So afternoon or evening dosing would be possible as long as the concentrations at the end of the dosing interval are enough to hold the symptoms. So kind of nice that we do have a little bit of flexibility with the dosing there. So tolerance. How well tolerated is this? So it's not a stimulant medication, but it is working predominantly on norepinephrine. These are the most common adverse effects, the ones that were found to be significantly more prevalent than placebo. It is by no means all of the side effects that are listed for the Viloxazine, but these are the ones that were the most common. In the clinical trials, they had groups that were 100 milligrams, 200 milligrams, and 400 milligrams. So I included them all across the board, as well as placebo just for comparison. So somnolence and fatigue, we'll come back to that one. This actually has been identified as a potential concern. That's why I mentioned the flexibility in when we dose this, as some patients may really get knocked out by this medication. So for those that require higher doses up to 20%, so 1 in 5 may have some pretty significant somnolence. So that would be something we'd want to keep in mind and maybe have to look at the administration time to help with that throughout the day. We still see some decrease in appetite, even with this product. We saw that with the stimulants last time. It still happens when we have an increase in the norepinephrine. Nausea and vomiting, these appear to be transient, where patients will experience a reduction in the reporting of these adverse effects as they go on. They could take the medication with food as long as it's not a high-fat diet to be able to assist with that. And then some insomnia and irritability also have been reported. Most of those appear to be transient, where patients adjust to that medication and then it's no longer a problem. There were about 3% of all of the patients who were given Viloxazine that discontinued during the clinical trials. The most common reasons for that discontinuation were somnolence, nausea, headache and irritability, tachycardia, fatigue, and decreased appetite. So these really were some of the drivers for why they ended up stopping. But most of the patients were able to develop a tolerance and continue with treatment. I was suggesting some of these, especially with the somnolence and fatigue. So we do have some warnings and precautions. It is a norepinephrine reuptake inhibitor. Similar to other medications in this class, it does carry a warning related to suicidal thoughts and behaviors. So the FDA did specifically ask that the manufacturer investigate this during their clinical trials. There was a higher prevalence of suicidal thoughts, ideation, and attempts in the Viloxazine group compared to the placebo group, but it was less than 1%. So 0.9% of patients in the active drug group reported suicidal thoughts, behavior, or attempts, and only 0.4% in the placebo group. So there were approximately 6 patients in the active treatment group, and there were 2 patients in the placebo group that ended up having those. So consideration, especially early in treatment, not a contraindication. So if somebody previously had suicidal thoughts, it's not that we can't use this, but it would be something we just want to keep in mind. There are a couple contraindications. So use with MAOIs, so our monoamine oxidase inhibitors, because it increases the norepinephrine, it increases the risk for hypertensive crisis. So we can't use those medications within a 2-week time frame of each other. And it's a pretty potent inhibitor of cytochrome P450 enzyme. So they recommend that medications that are predominantly metabolized by 1A2 or that have narrow therapeutic index, therapeutic windows, be avoided in combination with this product. So duloxetine was included there, theophylline was included there. Clozapine is one that's starred as something that you really want to be watching pretty closely. So that might be a place where we'd have to draw some serum concentrations and make some dose adjustments. So it does have some logistical things that we need to keep in mind with its use. Other warnings that it carries are activation of mania or hypomania. This is a class warning because it does inhibit the reuptake of norepinephrine. Cardiovascular, they did see some increases in blood pressure and heart rate. And I pulled what I could find from the clinical trials. So they had over 20% of patients who were on any dose of the Viloxazine have a 20 beat per minute or greater increase in their heart rate. So they did see this increase even with resting heart rate, not just with orthostatic changes. So they do recommend monitoring this in patients who are started on this medication. There doesn't seem to be a clear dose effect. So the prevalence was 22% for 100 milligram, 31% for the 200 milligram, and 28% for the 400 milligram. So if we are seeing tachycardia that's problematic for a patient, we may have to discontinue and swap to a different treatment as opposed to just being able to reduce the dose. So just something to keep in mind. And then we already talked about the somnolence and fatigue. So for those adolescents that may be driving, we'd want them to start at a time that they're not going to be driving, just to make sure that they can be safe and tolerate it. I gave you the teaser of drug interactions. So it is an inhibitor. We see those higher concentrations. These were specific drugs that were listed in the package insert in the prescribing information to avoid with the use of viloxazine. So a little bit different than the atomoxetine, where we have some more flexibility. We may have to be more specific if patients have other medications on board. It also is an inhibitor of 2D6 and 3A4, so it could even impact other medications aside from just the 1A2 agent. So maybe not something great to have on board with patients who have a number of other medications. And then the MAOIs are there just for completeness. I didn't want to leave it off there. All right, last piece, let's look at the data. So that's the logistics. How does it work? How do we process it? How is it tolerated? Does it actually work? Is it effective for patients? So the answer is yes. This is the pooled data from the phase 3 clinical trials. So I included both. There were 2 trials looking at the 6 and 11-year-olds, 2 trials looking at the 12 and 17-year-olds. But this review pooled all of those results into one analysis that just made it easier to look at. For each of those 4 trials, 2 of them were 6 weeks in duration, 1 of them was 7 weeks in duration, 1 of them was 8 weeks in duration. They all included at least a 1-week washout period. So if a patient had been on any other treatment for ADHD ahead of time, it was stopped. And then they monitored their ADHD rating scale to make sure that they were, that they were safe, but that they met the severity criteria for inclusion in the trial. A handful, actually, I think all four of them did allow some titration. Some of the patients were randomized to 100 milligram groups, so they didn't titrate anywhere. But for the rest of the patients, there was between 1 and 3 weeks to be able to titrate the dose up to whatever the last dose was. I included this one specifically because this is the one that actually included the 600 milligram data. I told you before that 400 milligram was the max. There's a reason for that. They didn't see as much additional efficacy with the highest dose. So I wanted to make sure that we represented that. And the main outcome that they used was the ADHD rating scale. So just as a reminder, this is an 18-item scale. It's a Likert scale. So it goes from, it's a 4-point scale. So the lowest rating is there's no symptoms present. The highest rating is these symptoms are pretty severe and interfere with everything. 9 of those items are inattention. The other 9 are for hyperactivity and impulsivity. So it really captures all of the different aspects of ADHD. All right. For these graphs, the CFB is the change from baseline. So how much did it change in the ADHD rating scale from their baseline score? The patients that were included had to have a minimum score on the ADHD rating scale of, hold on, I wrote it down so I wouldn't forget, and I totally forgot, 28. So it had to be at least 28. 28 is the cutoff for mild ADHD, so most of them had to be mild. In these clinical trials, the average score was in the low 40s, 43, 44, 45. So most of them were between mild and moderate in severity of their illness. What they found was for both cohorts of patients, we had a significant reduction in symptoms. So they did see pretty quickly a differentiation with the 100 milligram, interestingly, the lowest dose compared to placebo. But for all of the patients, by the 6-week mark, they did see a significant difference between active drug and placebo. Because just looking at those scores, so if it's 45 and you drop by 10, you're 35, you're still mildly ill. So I wanted to look at what the response rate was. This trial pooled all the data and looked at the 30% response rate. So how many patients had a 30% reduction in scores compared to placebo or compared to the baseline, and then how many had a reduction in their score of 50%. So it was each person compared to themselves. Of the bars, the blue one is placebo, red is the 100 milligram, green is the 200 milligram, purple is the 400 milligram, and blue is the 600 milligram. So what they saw was more than 60% of the active drug patients had more than a 30% reduction in their ADHD rating score. So that was considered clinically significant, that you'd be able to tell that there was a difference with this patient. In comparison, for most of the stimulants, these numbers would be between 85 and 90%, 85 and 95%. So we're definitely seeing effect in more than half, about 2/3 to 3/4 of the patients, but likely it's not quite as effective as what we saw with the stimulants, which isn't a surprise. For those that had a 50%, so their rating scale was actually cut in half, it was about half of the patients across the board. Now, just a quick peek, our 600 milligram group really didn't differ from placebo until the very end. And there wasn't really a significant increase in the number of responders compared to the 400 milligram group. There was still quite a few reports of adverse effects. They had more dropouts, and that's part of the reason, it seems to be part of the reason why they capped that at 400 milligrams and said that increasing the dose isn't giving us enough of an additional benefit to justify the burden of those adverse effects. All right. So that was a quick tour of Viloxazine. So one of the newest agents for ADHD. It is once daily, it is extended release. Generally, most of the patients did tolerate it. We saw some adverse effects, especially the cardiovascular ones we want to keep track of, but most of the other ones patients seem to tolerate pretty well. From an efficacy standpoint, it was statistically significantly better than placebo for both inattention as well as hyperactivity and impulsivity. We don't have too many head-to-head studies compared to the stimulants at this point, but just looking at our treatment response rates, we would expect that it really fits with where the other non-stimulant agents are. But it gives us another option for patients who haven't been able to tolerate or respond to some of those other medications. So with that, that's our